Mutational burden is a newer biomarker. The way we think about it is sort of working it in with the other biomarkers to get a feeling whether this is a patient who's more likely to benefit. And if I see someone who is PD-L1 high, but with low mutational burden and is a light smoker, I worry a little bit more about whether that PD-L1 is going to be associated with dramatic sensitivity. And if I see someone who's PD-L1 low, but has a dramatic tumor burden and is a smoker, I think to myself, wait, I should give this person a shot. And so it's certainly increasingly complicated. There's more and more data coming out about how to use these as orthogonal approaches. It's data that we have in front of us. And so we need to be more nimble about incorporating it. I don't think I want to overread into it. There still needs to be a little more validation to make it a robust biomarker. PD-L1 IHC is an FDA-approved biomarker. Tumor mutational burden is part of an NGS package, but not FDA-approved in that way quite yet. But we're finding more ways to work with this. So, for example, there's neat data in small cell lung cancer that if mutational burden is higher, the chance of benefit from immune therapy or combination immune therapy is better. Interesting. Now, I don't think about mutational burden in small cell as being a routine thing for me, right? So I have to think about we're increasingly trying to incorporate it into these key decision points as we want to be able to offer the best shot at these dramatic immune therapy benefits to any patients who can get it.
Yeah, and as a pathologist, tumor mutation burden is a tricky thing for someone running a lab and trying to incorporate it because there's no standardization at all across labs and across different testing platforms and how people calculate it, what panel they use. All the original data was on whole exome sequencing, and virtually no one does that on a clinical basis. And so trying to get some sort of standardization and validation of that approach across different labs, I think, is something that is really needed in the molecular pathology field, especially for an oncologist to get a value and really know that what that particular value means. Is it the same as a different test?
Yeah, it's a number. It's a specific quantification.
Right.
So it's not just high-low. There's high-low medium with every different number out there. And so how much can you trust that 10 is different than 11?
Right.
I will say that the whole exome sequencing data, it does seem like aligns well with the hard to capture targeted panel. There's some data to say that. So we do think that the targeted NGSs, but then there are all sorts of different targeted NGSs. And are those all the same? And those panels might or might not do better or worse at excluding germline mutations or other mutations. And so what do you count when you add these things up? It's still a little bit vague, and these needs to be refined some more.
Yep, I agree.